Hey class, so the second part of the lecture we're going to talk about exercise at altitude. So here's kind of what we hope to fully understand. So those acute and chronic physiological responses to high altitude. We'll focus briefly on the hemoglobin saturation curve, and then what happens to all these physiological variables as we're at altitude with exercise. So we know that we have sea level all the way up to extreme high altitudes. And the one thing to really focus on is really the amount of error doesn't really change as we go up to higher altitudes. As we can see, the percent of oxygen stays exactly the same. It's the barometric pressure that goes down and the partial pressure of oxygen that goes down the higher that we go in elevation. So as we climb elevation, we see pulmonary ventilation increase. So that's going to cause our tidal volume to also increase. So that sense of low PO2 stimulates chemoreceptors, which triggers that increase in ventilation. Means now we're blowing off more CO2. If we're blowing off more CO2, right, but we're not really exercising. So last time we talked about blowing off more CO2, it has to do with exercising at higher intensities, right? So since we're not exercising, but our ventilation went up, we could get into a state of respiratory alkalosis. Okay, and due to this, we see the kidneys end up excreting more bicarbonate, so that way we can actually reverse this alkalosis. So increased ventilation increases our blood pH, okay, and that's going to cause more bicarbonate ions to be released from the kidneys. The increased ventilation is due to the low PO2. Increased pH causes respiratory alkalosis, and as the bicarb gets released, and we start breathing out more CO2, there's a reduction in it, and now we can actually end up seeing how all this happened, and eventually gets to a point where our ventilation, our drive for ventilation will actually decrease, and alkalosis will be maintained, or alkalosis will be prevented from going any further. So pulmonary diffusion at rest does not limit gas exchange with blood. At altitude, our PO2 still equals our capillary PO2, but what we end up seeing is that in terms of oxygen transport, that we have a lower alveolar PO2, meaning we have lower O2 hemoglobin saturation. So this is going to change and affect our curve. So what we end up seeing, okay, here's, again, going over this curve again, oxygenated blood leaving the lungs, oxygen depleted blood returning from the tissues. And if I'm to go back to, where is the slide? Oh, our hemoglobin saturation curve. Yeah, or we'll work with this one. Oh, it says everything. Okay, on the red line, okay, in an unchanging environment, we'd see PO2 of about 46. So there's only about 80% saturation of hemoglobin compared to 97% at 104. However, with that increase in alkalosis, right, the curve is going to shift left right over here on the blue line, which will eventually allow more O2 to bind to hemoglobin because our body wants to compensate and provide the tissues with more O2. So in terms of looking at gas exchange, right, so typically we would see that when we're not at altitude, right, that the PO2, I think this one might be better, right, so let's look at 760 barometric pressure, 460, you see that the pressure of oxygen is way less, meaning the amount of oxygen that is getting to the skeletal muscles decrease, which would then end up impairing performance. Short term, what we end up seeing is a decrease in plasma volume within a few hours. So basically due to this increased respiratory water loss, we're going to see us lose up to about 25% of our plasma volume. So now that causes an increase in the hematocrit, meaning there's more red blood cells per ratio for plasma volume. Red blood cell count will eventually increase after weeks or months. And so this hypoxemia triggers EPO to release from the kidneys, increasing red blood cell production. Cardiac output, okay, is going to increase despite a decrease in plasma volume and a decrease in stroke volume, and this is at rest and submaximal exercise. Okay, so that way we can deliver more O2 to tissues per minute. So that heart rate is going to drastically increase. However, this is only a short-term adaptation. okay, and highly inefficient. After a few days, our muscles learn to extract more O2 and reduce the demand for the increase in cardiac output. So exercise at maximal intensities, okay, and altitude, all of these things actually go down at max, okay, and now VO2 would then go down as well. As we hit higher altitudes, our basal metabolic rate increases, okay, which means we need to also increase our food intake, more reliance on glucose than fat. We don't really understand fully, but what we end up seeing is that we increase anaerobic metabolism and increase in lactic acid as we are at higher altitudes, but over time that lactic acid production will begin to decrease. So here's acute hypoxic effect at rest versus hypoxic effect at a given submax exercise intensity. You can see respiratory, cardiovascular, metabolic, as well as renal in terms of the kidneys and what happens. So after chronic exposure, we see an increase in ventilation at rest and during submaximal exercise, right? It only makes sense that we would see that increased ventilation. So resting ventilation is about 40% higher, submax 50% higher. We start to see an increase in EPO even after just 2 to 3 days. And here's just to show you guys what happens after days, weeks, okay, months at high altitude exposure, days, weeks, months, okay, high altitude exposure versus what everything looks like at sea level. And what you can see is that even after months of being at higher altitudes, that our resting heart rate maintains elevated, okay, that our pH never fully comes all the way down, right? It's still slightly elevated. VO2 max never fully gets up there, neither does cardiac output, and then our ventilation is going to be increased as well. So in terms of muscle, what we end up seeing due to that increased metabolic rate, we can see a decrease in the cross-sectional area. We tend to see an increase in the capillary density to get more oxygen. We see the mitochondrial function decrease, meaning our oxidative capacity is going to go down as well. And really all of this starts to happen as we get above 1,500 meters and the atmospheric pressure gets below 131 millimeters of mercury. So here's just a graph showing you as you climb in altitude, VO2 max goes down. Anaerobic performance is affected the most in these hypoxic conditions, obviously. And the idea of when we start talking about training is we want to live high and train low. Living high, right? If we train high, we're not going to be able to train at as high of an intensity, right? Because our VO2 can't get as high. However, if we live high, we get all of the physiological adaptations, primarily that increase in EPO, right? So increasing EPO increases red blood cell production. And then train low, meaning now we're training at a high enough intensity. Okay, so when it comes time to race time, we are familiar with exercising at that intensity. So living high and training low has shown the greatest improvement on a 5K run trial time. And here's just some studies to show you guys if we're going to perform in a race, okay, we would want what it looks like in terms of depending on the altitude that you're at, okay, and then you came back for a race, so immediately post altitude, the change in time trial performance, and then 2 weeks post altitude, again depending on the altitude that you're at. Okay, again just another change in VO2 max, something that you guys can see. Obviously when we were living high, our VO2 ends up getting higher when we come back to sea level, right, because we had those EPO adaptations. So some two ideas or strategies: compete immediately once we hit altitude. So if we're going up to altitude for a race, compete ASAP. Doesn't confer any benefits of acclimation, but it's too soon for adverse effects, right? And then, or we can take about 2 weeks before competing. Those adverse effects are down, and aerobic training at altitude, though it's not as effective, okay, we're still able to get over these adverse effects and perform.